Well, let's get the ball going. So, hi, welcome to the Q&A. I think more people will be trickling in as the time goes by. My name is Mike Green. I'm the Chief Medical Officer of Winona. I'm an OBGYN and really happy to be here to really answer your questions and to serve you. And I'll let everybody else introduce themselves.
Did you want to introduce yourself, Anna?
Yes, I think Dr. Green stole my thunder there.
Sorry, I don't like dead air. Sorry, and we were kind of just standing there staring at people.
Well, then you said 5 minutes grace, so then you're throwing me off. So
okay, because you started the event.
Well, let's get the ball going, guys. Let's get the ball started. So yeah, my name is Anna, and I'm so happy to be with you guys here today. I work in our marketing department, and going to be helping to facilitate to make sure all of your questions get answered. And there will also be a recording of this afterwards where some of your questions will be highlighted as well.
And I'm Dr. Brown. I'm one of the Winona doctors. I started out with Winona in the state of Pennsylvania, but now I also take care of patients in Florida, and recently just took over taking care of patients in Hawaii as well. So I'm physically located in Pennsylvania on the East Coast. So for my Hawaii patients, I'm going to be on a different time zone than you. I am a board certified OBGYN as well. I was in the Army for 12 years, and so I traveled around quite a bit. I've lived in Hawaii, I've lived in Texas, lived in North Carolina, and taken care of a wide variety of patient populations in different ages of women. And now my focus is taking care of women in the middle part of their life and in this transition of perimenopause and menopause. And that's why I'm here at Winona, to help you through that, because I'm personally going through that as well. So I kind of have a personal keen interest in this, and I want to help other women go through this journey as well. And then we'll have Dr. Dumbo.
Yeah. Hi, everyone. I'm Dr. Dumbo. I am a board certified OBGYN as well, just like Dr. Kat Brown. I am also going through the menopausal transition, so I have a very keen interest as well in being able to understand this for myself, but also to be able to help other women who are going through that as well. I am based in California, on the West Coast. Love experiencing the sunshine, and also grew up overseas in Zimbabwe. So I really do appreciate all of this from a global perspective. I appreciate seeing women who are in different cultures, different backgrounds, and how they also experience the transition. So I'm very happy to be here, and I'm happy to be able to answer any questions that you guys have today.
Talking about questions, please put your questions in the chat. Otherwise, we're going to be sitting here exchanging pleasantries for an hour. So we really want to answer your questions. It works better if you ask some. So please, I know you all have questions you've been holding on to. That's why you're here. So start typing them in. So we can answer them. I'm going to actually, we sort of missed Breast Cancer Awareness Month last month. We were just talking about that. Dr. Brown was sharing that she recently got her mammogram. By the way, just a little anecdote. So I'm not going through the menopause transition, but my wife is. And she's a Winona patient. I'm very happy. But interestingly, last year, we paid cash for my wife's mammogram, and I happened to be getting the oil change in my car the same week, and it turned out that the oil change was more expensive than the mammogram. So get your mammogram. If there's insurance problems, it's not that expensive to do it out of pocket. Like I said, it was cheaper than my car's oil change. So preventive maintenance is important for yourself and your car. But Dr. Brown, did you have something?
Yeah, no, I just wanted to say, it's one of those things that a lot of women dread, and you hear these rumors about what a mammogram is like and how uncomfortable it's going to be, but it really is not bad. And it's relatively quick and painless. And the mammogram techs are fantastic, but it's one of those necessary evils that you need for your preventive health. And most insurance plans do cover preventative medicine, and you don't really have to pay out of pocket for that. Although it's interesting that, the mammogram would be cheaper than an oil change. That's quite an interesting factoid, I think. But I think it's important. I think, one of my tenets for my patients, especially like throughout my career, I think it's really important that we empower our patients. And, I really take pride in counseling patients that I really want them to be the captain of their own ship. Like, this is their body, their health, their world. And I think it's really important that you take your health by the reins and that you really stay on top of things and that you really take care of yourself. As women and as mothers, as wives, and, in workplace too, we're really, really good at putting ourselves last sometimes. And we almost need something to kind of trigger us to do self-care and to give us the impetus to really prioritize ourselves. And I'm telling everybody right now, like, now's the time to be selfish. If you in your 20s, like, could really kind of get through and balance everything, you did okay. In your 30s, 40s, 50s, you're going to start to notice that you can't really do everything the way you used to. And now is the time that your body is going to, remind you that you really need to take the time and take care of yourself. And so the mammogram is part of that. But also just, your health and wellness, eating well, moving your body, exercising, now is the time to do that. So that's my PSA for the night. I don't know if you guys want to add anything to that.
I would just reiterate everything you said, because I think, I think about, my parents, for example, as they age, there's so many concerns that they have. And it's like, so really being able to look at, okay, I don't have children, but if I had children, here's the children, there's the parents. We're pulled in so many different directions as women in this stage of life that I think being able to actually say, wait a minute, I am worth investing in me, even if it's the small things, like just like Dr. Kat said, moving your body. It can be as simple as just going on a walk. Right before this webinar, what did I do? I went out and I said, I'm going to take a bit of time to meditate and go down the street, walk and come back, really just to get my mind clear, for this time that I get to be with you guys. So I think small decisions like that are so important. And being able to learn what we need as women, not only from the perspective of managing our hormones, when we go through the transition, but I think there's so many more things that entails, and we're very happy to be here to answer those questions too.
Thank you guys so much for your introductions and opening remarks. I'm going to go ahead and start sending you guys the questions. Keep them coming though, and we'll try our best to get all of them answered before the end of today's Q&A session. So the first question from Julie says, how long does it take for the hot flashes to go away? So once you're starting your treatment, how long are you starting to see improvements?
Who wants to take it?
I can take that one. Okay. I think it's different for everybody, but for the most part, what we typically say is the first 2 weeks after starting, any hormone replacement therapy or menopause hormone therapy, however you want to term it. But I think, for your body to adjust to the estrogen, depending on whether you're on the cream, you're on the pill, or you're on the patch, it can take at least 2 weeks for your body to kind of adjust and stabilize. You may notice an initial increase in hot flashes if you're using the cream or the pill. But eventually by 2 weeks, you should really start to notice, some level of a decline. And we typically say by the 3-month point, like if you aren't experiencing a decline in your hot flashes, we start talking about changing your dose. I don't know if anybody else has anything to add. Yeah, I don't know if you guys have anything else to add.
I think you covered it well. All right. So anything else to add before we go on to the next question? And hopefully, Julie, that answered your question as well. All right. So the next question is from Tammy. Welcome, Tammy. Is there a danger or any type of symptoms or anything around HRT that they should be aware of?
Well, I would start off by saying that there is no medication anywhere without risk. Even Tylenol has risks if you take too much. So, everything, when we're talking about medication, we're talking about treatment, it's always about the risk and the benefit. So there are some risks involved with hormones. However, the hormone doses that we use with hormone therapy are much lower doses than often what a lot of us have taken for birth control in the past. The main things we worry about about are, you'll hear about the risk of cancer, you'll hear about the risk of cardiovascular disease. And really those risks are lower. The risk for cardiovascular disease is lower for women who start HRT before the age of 60. And also, when we're talking about the risk of cancer, I think that it's important to think about our genetic risks as well, and just our lifetime risk as women as well. So if you take hormone replacement that has a combination of estrogen and progesterone, you can have a slightly increased risk of breast cancer. However, if we live long enough, most women are going to be at risk for breast cancer at some point in our life. So we have to balance what your quality of life is versus what those risks are. So, when we talk about these risks, we can't, as a physician, tell you, in 10 years, if you take this medication, you are going to get this. Like, we talk about probabilities and statistics, and overall, these risks are low for most women, especially if we use the tenet of using the lowest dose that you need to help with your symptoms for the shortest duration that you need to. And so that's something that we consider as well. But just like I said when I started, no medication is without risk. And so it's something that you as a patient have to balance. And so when you start that conversation with us, if you're starting with Winona, you can talk to your doctor about this, and we can answer your questions and get into this a little bit more further with you on an individual basis, like after we review your medical history.
So I like to add, I'm a big picture guy. And so if you look at the big picture, ultimately, the one thing I can guarantee you is we're all going to die of something someday. Okay.
Yeah.
There's kind of a joke. The one thing everyone in the world can agree on is everybody has to die at least once, right? So the goal is to put that off as long as possible and to stay as healthy as possible while you're trying to put that off. And so if you look at women that start HRT before the age of 60, and you compare them to women that have never had HRT, those women that started the HRT live a longer life, they have a longer life expectancy and a healthier life than women that don't ever have HRT. So if that's really the goal, HRT should help you achieve that goal. Now, you can always cherry pick this little piece over here. Well, gee, there's a higher chance of this thing. Yeah, but then there's a lower chance of this thing. And so for me, the big picture is this helps you live a longer and healthier life, which is kind of what we're all after. And so assuming you're an appropriate candidate for HRT, and quite honestly, if you survive our screening questions and you get to the point where we offer you medication, then you are a good candidate for it. Then on average, you're going to live a longer, healthier life with the hormones and without them.
Thank you guys for those answers. Next question is from Lauren. She's a retired veteran, so thank you, Lauren, for your service too. And she's asking about hormone testing, and would she do that with an OBGYN, or do we do anything like that here at Winona?
Well, so number one, Lauren, thanks for your service. And I'll speak up because I'm the other veteran here. So the VA health system is a very interesting thing to navigate. So good luck with that. And just make sure you take your own notes, because I'm in that same system as well. Number one thing is you don't need to get your hormones tested. So this is one thing that, based on your symptoms, it's best to treat based on your symptoms and how you're feeling. The hormones really don't give us that much information that can be helpful for us when we're prescribing hormone therapy. So if you come to us and you fill out our questionnaire, we have basically a symptom picker that you'll go on and you'll log what symptoms that you have. And we can tell by the symptoms that you chart what that indicates as far as what hormones are low for you, and how we need to cater your treatment. So you don't need hormone testing. And unfortunately, there is so much out there in the media, and there's so many other clinics and places and other sites too that are really prompting women to get hormone testing. They're pushing, salivary hormone testing and hair hormone testing and Dutch hormone testing. And really all of these things are expensive and not necessary for you to get the treatment that you need during this point in your life. So you don't need that. But if you're looking to get hormone therapy, you're in the right place. Winona is a good place for you to get that. If you are more interested in seeing somebody locally, it could be an OBGYN, but also family practice doctors, internal medicine, all prescribe hormone therapy. But we're here because a lot of doctors in the US don't feel comfortable prescribing and don't really have the experience with it. So Winona exists because there's not a wide array of physicians that are out there willing to help women. And so we're hoping to change that climate. I think we are little by little as we expand to more states, right? But yeah, so come see us at Winona.
Can I just add something to that, Dr.
Sure.
So I also think that like what we tend to do is look at your symptoms, right? Like depending on what your spectrum of symptoms are, we also have an algorithm by which we look at your BMI and kind of figure out the best appropriate dose. And then based on that, we do a follow-up in 3 months, and then we're able to kind of reassess based on your symptoms, whether or not we kind of tweak it as to how you have responded to that initial dose we started with. So just so that you feel reassured that we're not just, throwing different, doses out there willy-nilly or treating everyone with the same dose, we really do look at, for you as an individual, what dose would be the most appropriate, and then how do we follow up on that?
I like to say, I've got hypertension. I'm on blood pressure medicine. Nobody checks my blood level of my beta blocker to decide if I need a higher dose. They check my symptom, which is my blood pressure. And they say, oh, your symptom is getting worse. You need a higher dose of beta blocker. They don't do a beta blocker blood level. And it's really the same way with HRT. We look at your symptoms. Are they getting better? Are they getting worse? Are you having side effects? And then we affect the medicine based on that. And the algorithm that Dr. Dumbo is talking about, I basically designed, and it works pretty good. I specifically made it to sort of slightly underdose because I'd much rather have to give you a little bit more because I didn't quite get all your symptoms under control, than have to back off because I caused side effects. So don't be surprised if you're better, but you're not completely better. We need to add a little bit more. That's a kind of a safety feature that's built in, because it's a better way to titrate up rather than say, oh, because you problems, let's titrate back down. So that's how the algorithm is sort of designed. It's the theory behind it anyway.
Thank you guys so much for your answers. Next question is from Julie, and she's asking about being on HRT long-term. Mentioned that a doctor said that it's possibly bad to be on it long-term. We want to hear everybody's thoughts and feedbacks on that.
Well, I would say consider the source of who's saying what. I mean, really, you need to be on HRT for as long as you need it personally to help your symptoms. There's really no increased risk, and I don't know how you would define long-term, what's the definition of that. So I think that, each woman, it's an individualized decision that you make with your physician. And we talk about the dose that we're going to order and what's best for you. Most women tend to be on hormone therapy, maybe about 3 to 5 years. And at the end of that, at any point, if a patient comes to me and they say, I want to try going off this medication, then we talk about it, and they may make the decision to try to go off of it. And if their symptoms return and they want to go back on, we do that, but sometimes they do well off of it too. So it's an individual decision for most women.
Thank you so much for the answer. Is there anything else that you guys want to add before we go on?
I just want to reiterate what Dr. Kat said. It's so individualized. I mean, there's some women who've been on it until the day that they die because they know that based on the fact that the timing of when they started it, like let's say you start it within the first 10 years after you've had your last menstrual period, as long as you're doing fine and you are not having any adverse effects, you can be on it until the day you die. Some patients feel a little bit less comfortable with that and would rather try to wean it off after 3 to 5 years. So it really is an individual decision.
The other thing I would add, I agree with everything that's been said. If you do decide to go off of it, choose a smart time. So don't do it just before your kid's wedding or something. Choose kind of a relatively stress-free time so that if it backfires on you and it's like, oh my gosh, I feel terrible, I need to go back on this stuff, you're not kind of in the middle of crisis mode. So, you want to be smart about it, but it's a reasonable thing to do is to stop it. It's not dangerous to stop it. And so if you're on it for 3-5 years and you're like, I wonder if I still need this, you can go off it and see if you do. I think it's a mistake. Every now and then I have somebody we check in at 3 months and they're like, oh, I feel better, I'm going to go off it. It's like, oh, it's kind of early for that. So, you do want to give it some time, but it's also reasonable to stay on as long as it's helpful for you.
Thank you, everybody. Next question is from Nancy. Welcome, Nancy. So happy to have you here today. She's asking about the symptom of brain fog and how effective HRT is on brain fog.
Who wants to start talking about that? I would say that, my explanation is estrogen in a woman's body is beneficial to every tissue in our body. It is integral for the optimal functioning of every organ that we have. It gives our tissues the best qualities that they need to function the best that they can. So when it comes to brain fog, this is something that is so common, and it can manifest in different ways. Some women describe the brain fog. Some people will start to feel like all of a sudden in the midlife they have ADHD and they can't stay focused. It can also manifest as mood changes, because that can affect the brain as well and our neurotransmitters. And so it can manifest as more depression or anxiety symptoms or obsessive compulsive type behaviors. So, the HRT, when we give your brain back that estrogen, it really allows your brain to function at its best. Just like your skin gets better, it's cardioprotective as well. There's so many things that the estrogen does that's positive. So that's how it affects the brain fog in my mind when I think about physiologically how it affects. And I think for many women, it's very helpful. And I've had patients that have wanted to go off HRT because they felt like they were time to stop after a few years. And the brain fog, when it comes back, they're like, no, I didn't miss that. Please put it back on. Please reorder my medication. Because it's the clarity of mind is so valuable. Something that we all want to keep.
Yeah. I 100% agree, Dr. Kat. And I think one of the things that I encounter sometimes with patients is the experience of, I'm at a crux, at a road, at an impasse. Do I go on medication for ADHD, or do I, start hormone replacement therapy? And a lot of times, what I will encourage patients, because again, it's a very real phenomenon, the lack of concentration, feeling of confusion, you feel like you're forgetting everything. That's just a combination of symptoms that, manifest as a result of the reduced estrogen levels. And a lot of times, you can try, a 3-month trial of, hormone replacement and see whether or not, your symptoms improve. And a lot of times, if that's the case, you may not necessarily have to pursue the avenue of ADHD medication. I'm not saying you don't, but I'm just saying that it's at least a very simple way of determining what is it that I need at this particular point in my life.
Thank you guys so much for your answers. The next question is from Carlene. Thanks for joining us today, Carlene. She's asking if there's anything like HRT out there for men. See how you guys want to answer this. Maybe Dr. Green has some insight.
So actually, I'm a board certified OBGYN, but I did a family practice residency before I did my OBGYN residency. So I actually got boarded in 2 different disciplines. So I'm actually somewhat qualified to answer this, although quite honestly, I haven't done family practice in a long time. But for men, testosterone is the main hormone for men. And so TRT, testosterone replacement therapy, for men is a real thing. And men do go through not nearly, I'm sorry, ladies, thankfully for me, not nearly as big of a change that women go through during this sort of midlife time. But they do, for some women, for some men, it can be fairly significant, and testosterone replacement therapy can help. It's not something that we do at Winona. Our idea, it's always been do one thing, do it really well, and don't mess around with things we don't do so that we don't hurt anybody. So we're like really concentrated on this one thing. So we don't treat men because we're not good at it. And quite honestly, as OBGYNs, not particularly qualified. But there are other sites that do TRT for men, and it can be helpful.
Lauren had another question, and it's about if mood swings, if she could tell if the mood swings are from her hormones or if it's just part of what's going on in her life. For example, she mentioned that she's a mom. So how can she tell if it is from her hormones, and how can she tell if it's related to menopause or if it's just related to stress or other factors in someone's life?
I mean, I guess if you go on vacation and you get out of your environment and you're still having the symptoms, then it's not just the environment.
Yeah. I think one of the things that I think about as well, like, because during this whole transition, right, there's so many things that are important to help us, our overall wellness, right? Stress reduction is one, right? And so if we're looking at all the different things that we're looking to accomplish just for our overall wellness in this midlife period, and you're still having these mood, or your family is telling you and giving you input, wait a minute, something is not right. I'm noticing that you are way outside of norm. I think these are just key indicators that there may be something else that may be going on besides just, normal stress, or if you can't tell yourself that, man, the percentage of time that I'm experiencing these mood swings is way out of proportion of what I normally experience, it's worth at least asking the question as to whether or not this could be something that is linked to a series of other symptoms that I may be having, like hot flashes. If you start noticing that the mood swings, you're noticing other symptoms that are part of the transition. I think that's where you're able to ask the question as to whether or not this is part of the transition.
And it's probably a mixture of a lot of things. It's usually not just one thing. But let's say that you weren't going through the menopause transition. There's a certain amount of stress that you can handle before your body starts decompensating with mood swings and different stuff. And that sort of threshold may decrease as you go through the menopause transition. So, there's still all that stress coming at you. It's just that you can't handle quite as much of it before you start decompensating. And so adding hormone replacement therapy may help bring that threshold back up. It doesn't mean there isn't a point, because your kids know how to hit those buttons, where it's not going to make you immune from that. It doesn't turn, there's still kryptonite out there. So your kids are going to still drive you crazy, but you're going to be able to hopefully tolerate a little bit more before you sort of blow your top or have other manifestations. So yeah, if nothing else, it's worth a trial. Give it 3 months and say, hey, do I feel different or not? And you might decide, wow, this is really helping. Or you may say, this isn't the right thing for me.
Thank you guys so much for your answers. Next question is about, and we've talked about this just briefly before, but high blood pressure, your blood pressure going up and menopause. Is there any correlation? Is there any impact that HRT can have on lowering your blood pressure?
I can speak to this, but I don't think that there's any direct correlation between menopause and high blood pressure. However, there is a known correlation between menopause and heart disease. And so, one of the reasons why we say that there are short-term and long-term benefits of hormone replacement therapy is that the long-term benefits are really very cardioprotective. So really protecting your heart from, some of the, known risks that come with heart disease as you age, as you go through the aging process. I don't know if there's anybody else that wants to add anything.
I mean, age in and of itself is a risk factor for high blood pressure. And so as we all age, male or female, there is an increased risk of hypertension. Estrogen is, as you said, cardioprotective. I don't know that it's necessarily protective against hypertension. And in general, we want to make sure that your blood pressure is controlled before starting on HRT. So that's kind of one of the important things. So if your blood pressure is kind of out of control, you really need to see your primary care doc and get that under control. And then starting hormone replacement therapy after that would be more appropriate. HRT as a primary treatment for hypertension isn't sort of really standard of care. And I personally wouldn't use it that way. Now, on the other hand, if you're finding that your blood pressure is generally fine, but if you get this terrible hot flash and you check your blood pressure and it's up right when that happens, that's a kind of a different thing. Or if you're finding that sort of your threshold for blowing your top has gone down, and when you blow your top, your blood pressure goes up. Those are situational things, and that's different. But if your blood pressure at rest is elevated, that really needs to be dealt with primarily and not necessarily with HRT. That's kind of how I would think about it.
Thank you, guys. I'm going to go out of order just for a second because somebody else put in the chat from LaShawn mentioning about hormonal imbalance and raising your blood pressure, similar to what we just talked about, but want to see if there's anything that you guys can say about that as well.
What was her specific question?
She's mentioning that if you have the hormone imbalances, that it can raise your blood pressure. And I wanted to see if there was anything else to add specifically about, not necessarily when you're going through menopause, but more generally if your hormones are out of balance. I think it's similar to what we were talking about earlier about hormone testing and just seeing, what hormones that you need. But I think
there can be situational, it's a situational hypertension rather than an essential hypertension. And they're really different things. So most people's blood pressure will go up when they're really stressed or they're angry or, things aren't going well. And that's normal physiology. On the other hand, if your blood pressure is high at rest, that's not from the menopause transition. It's really a different issue. So yes, hormone imbalance can cause high blood pressure, but it's really a situational high blood pressure. And it's really a different type of high blood pressure than essential hypertension, which is when your blood pressure is high at rest for no particular reason. And they really are treated differently. And I kind of tried to explain that. Maybe I didn't do a very good job, or maybe the question was asked before I did. But that's kind of the way I would explain it. I don't know if you two have another way to talk about it.
No, I think you did a great job. I agree.
Yeah. Okay. So next question is from Shannon, and she's asking if HRT can help with your libido.
Yes, it can. Going back to the whole estrogen is good for every part of a woman's body. Part of why libido changes is just because our bodies don't feel great. They're not functioning at their best. So, and also a big part of that too is that with the loss of estrogen, we lose, the lubrication and the elasticity of the vagina. So sex itself can become more uncomfortable. And then that's kind of a negative feedback loop that we get into, right? So then when you have sex and it's not comfortable and you're not really able to enjoy yourself and you're not getting pleasure from it, how likely are you going to want to be to do it again? So your libido starts to tank down. So by replenishing that estrogen and getting those tissues healthier, it can help with libido and it can help, with that desire and make sex more comfortable. So it can definitely help with that.
Yeah, along the same veins, if you're up all night with night sweats or because you're peeing all night long and you're not getting any rest, when we're exhausted, we don't want to have sex. So again, it can treat libido in that way too. So there's a lot of different things that play into this that it can help with. But definitely HRT for a lot of women does a really good job at treating libido issues.
Okay. Thank you guys so much for your answers. The next question from Sheila, and thank you so much for writing to us. She's asking about energy levels and fatigue, which we've touched on a little bit, but love to see if you guys have anything else to add. She also mentioned that she had a complete hysterectomy, which I know we've talked about before. So love to see if you guys want to touch on first tiredness during menopause and how HRT can help with that, and also HRT and a complete hysterectomy.
So I'm cheating and reading the question. So I'm going to we do this periodically. So there's a disconnect between what a patient means when they say a complete hysterectomy and what an OBGYN means. The terminology is kind of messed up. And I'm looking and seeing that you had your ovaries removed. So I understand what you mean. The ovaries are separate when we talk about the type of hysterectomy. it's kind of not as important. But just to put that out for all of us. So you're talking about having both your uterus and both your ovaries removed. So I'll just throw that out there.
Yeah, I mean, when Dr. Green was talking about, getting better sleep, affecting the libido and improving that's also directly how it can help with fatigue and energy level too, right? So, not only is our sleep affected by menopause and the hot flashes and the night sweats, but just overall dealing with these symptoms that are disruptive to our daily life and disruptive to our day also raises our stress response and our cortisol levels. And so it's almost like several times throughout the day, we're in this constant fight or flight, and our body's responding negatively to these symptoms. And over time, that takes its toll on you, and it does expend a lot of energy. And so you're going to feel tired, you're going to feel fatigued, you're going to have low energy. And then you go to bed at night hoping to get the restorative sleep, and then you're up all night with night sweats again. And it's this vicious cycle. And so by replenishing your body's hormones and giving you hormone therapy and improving those symptoms, we can also affect your energy level, and that fatigue, it generally gets better as you get more restorative sleep again. And insomnia is one of the things that most of my patients are so grateful to combat when they get on their hormone therapy. There's nothing better than a good night's sleep. And as OBGYNs, I think the three of us really, really value sleep because we're so used to being sleep deprived so often. But I think that menopausal women are another population that are used to just not getting great sleep. And so when you get it, it feels so wonderful.
Yeah, I 100% agree. I think for me, one of the biggest things that kind of tilted me over to transitioning to starting hormone therapy for myself was the massive amount of fatigue, right? Like I already know what my body can handle after doing a 24-hour shift. I know but this was like the whole weekend would go by and I could only do one thing because I was just chronically exhausted. So I know that that experience and that feeling of not being able to sleep, combined with just this feeling of a lack of energy and transitioning to starting, the estrogen replacement, and the absolute restoration of what it felt like to be like, wow, like I actually feel energized. I actually feel like I'm back to my normal self. And so again, it's a lot of what happens is, our ovaries are not producing the amount of hormone, just as Dr. Katz said, and replenishing it can almost feel like even it's just like a little top up, a top up of what my body is not able to do. And the results are that, you're able to experience just that sense of rejuvenation. And that's what is so fulfilling in being able to see other women get to experience as well.
Mm-hmm. Absolutely.
Thank you guys so much. The next question is from Jay Franco, and it's talking about getting your period during menopause. She mentioned that once she started going, and I'm not sure for her if it's perimenopause right now or menopause, but just said when she was starting getting her period 3 days earlier in a month, and had a normal cycle when she was younger, and now her cycle is going back to some previous patterns. So to summarize the question, it's about your period once you start perimenopause.
I mean, it's very, very common to start having bleeding irregularities, especially as your body is going through this change, because the communication between your ovaries and your uterus is going to change based on what your hormone production is, what's it doing from your own ovaries. So that's one of the first symptoms that a lot of women will start to recognize, is that suddenly their period has no rhyme or reason. You may skip months, you may have 2 in a month, you might start to notice the cycle getting shorter, like you mentioned. Like if you were regular every 28-day cycles, you might start to notice your periods every 23 or every 24 days. And sometimes you just may not be able to even know when you're going to get a cycle. And every woman's experience of that is different. But that's absolutely part of this whole spectrum of symptoms that we start to see with perimenopause.
And I think I just wanted to address, because I think there was Shannon who had asked a question that we're referring to menopause primarily on this call, but no, we're referring to the perimenopausal transition, the menopausal transition, which is perimenopause and menopause. So I haven't even hit menopause yet, but I'm in that perimenopausal transition. So everything that we're talking about now is absolutely pertinent to whether or not you've completely stopped having a period, whether you're still regular but having symptoms, or whether you're skipping your periods left and right, or really having these prolonged episodes of bleeding. That's all part and parcel of the transition.
Yeah, thanks for adding that. I also dropped a resource that we have on our website for effective perimenopause treatments. And there's a lot of resources. If you just use the search bar, you can find some additional resources on perimenopause. And we'll probably address that in a couple other questions as we go forward as well. So thanks so much for adding that, Dr. Dombo. Next question is from Clarissa, who is actually a current patient. So welcome, and glad you're here. She's been on the cream, and she has the 25 milligram DHEA now for 4 weeks. A couple of her symptoms, hot flashes and night sweats, are completely gone. She's asking, when should she expect her libido now to improve? Wanted to see if that takes longer than some of the other symptoms, if there's any patterns around that.
Well, I think that, libido is something that is multifactorial. It's not like we replenish the hormone and suddenly we push a button and your libido is like back to normal. Everything's great. The way I like to explain this to my patients is that for women, our largest sex organ and the most important one is actually our brain. Yes. So it's so important that you need to really look at your relationship with your partner. You need to look at, are you making time for it? And that's something that, we can't just flick a switch like men. Like men, you just look at a guy and say, hey, you want to do it? You want to do it? He can flick a switch and be ready. Women, we have to be treated like a classic car. We have to be wined and dined. We have to have the right headspace. Forget it. If our partners don't help with anything around the house, they leave a pile of dishes in the sink, forget it. Libido is out the window. It's just not going to happen. So there's a lot of other resources available out there. But I encourage my patients to really go back to thinking about the grassroots of their relationship, whether you have a male or female partner. Go back to when you were dating. What did you do to woo each other? What did you do, to get in the mood? You got to go back and do those things. We get so much in our patterns and our routines, and we expect that we're just going to be able to fit in sex like it's a scheduled event, like going to the store, and it's just not. We have to prepare our brains and get ourselves in the right mental headspace. And so there's a lot of other things that you need to do to kind of help foster that. And there's some websites out there. We've talked about them in prior webinars. There's one called OBGYN, which is a website that's purely devoted to women's sexual pleasure and orgasm and libido. There's also an app that was invented by an OBGYN called Rosie, which is an app that is also used for this purpose and to improve sexual function and libido. But I think, and even going back to something, there's a book called The Love Languages, which there's websites now, there's apps with it too, where you and your partner can take a quiz and figure out what's really important for you in a relationship, how you need your partner to respond to you in order to feel loved and to feel wanted. And that those things, these other things that you can do for homework, basically, really can help your libido as well. It's not purely a hormonal issue for us. So, but if, when it comes to the hormone treatment, I think that 4 weeks is kind of early. I think the hot flashes and night sweats are usually the early things to respond. You should start to get some improvement with libido related to the hormonal parts of it, but you got to do the work of the other stuff too. So, yeah.
I'm going to jump on to something else you said earlier too, is that unfortunately there's this negative feedback that happens, particularly with some of the vaginal changes and the decreased lubrication, discomfort, the tiredness. And so there becomes this negative feedback. It takes a while for these tissues to change back. But even once the tissues have become healthy again, you've got to overcome that negative feedback. And that takes time to start establishing the positive feedback loop to overcome this sort of negative training that your body has had inadvertently because of these changes. And so there's the physiologic changes that take time. And I would say 4 weeks is probably a little bit early. Usually 8 to 12 weeks, I think is more realistic. But then once those changes happen, then it's got to start changing psychologically with a more positive feedback rather than the negative feedback you've been experiencing. The other thing, when I have young couples, especially after they have their first baby, the thing I always like to tell the husband is, at this stage in life, foreplay is doing the dishes and putting the kids to bed. And so, yeah, I agree with what you say about that.
There's actually a book that you can buy. It's actually called Porn for Women. It's a little like coffee table book, and the front cover is actually a man pushing a vacuum. And it's the entire book is pictures of men doing like domestic duties, which is kind of interesting because it's not porn at all. But yeah.
Well, I like that answer. That's probably my favorite so far. Next question is from Lo. And I'm sorry, add some details in the chat if I missed anything here, but she's been doing fairly well with menopause, actually as a health coach, and has been managing her nutrition, probably doing all the right things for her hormones to keep them in balance. She also mentioned her height and weight at 5'2", 113 pounds, and mentioned that she's struggling with the muscle tone right now because she's a lifter. She has elevated LDL and overall good cholesterol. She wants to know what she can expect from HRT for her.
So I can tell you the DHEA in particular should be very helpful for increasing your muscle mass. In fact, not at the doses we prescribe, but it is used as a performance-enhancing drug in the bodybuilding community. So we don't prescribe those kind of doses. But even at a small dose, it definitely can help increase your muscle mass, especially as a response to lifting and exercise. So the estrogen and progesterone can help as well. I think for you, for that particular symptom, DHEA can really be beneficial for you.
And just to add to that, Dr. Green, or what Dr. Green said, the reason why DHEA is beneficial is because it gets converted to testosterone, right? And testosterone, I think, is the aspect or the part or the hormone that your ovary normally produces that declines during the perimenopausal transition that's responsible for muscle mass. So the reason why DHEA is beneficial is because it gets converted to estrogen and testosterone.
Thank you guys so much. The next question is about the quality of HRT products as well as the ingredients. And I'll actually I'm going to drop a link in the chat, the ingredients. You can find that information on our website as well. But I'll just open it up in case you guys want to add anything general.
You want me to grab that one? So that's a really important question. And it's something that you should definitely ask. Especially when it comes to compounded medications, because compounding is a bit of an art, and not all compounding medications are the same. And it's really important to make sure that you're sourcing your compounded creams from a really good, reliable source. So one of the big advantages we have is that we own our compounding pharmacies. So we have control over the quality of this, what goes in it, who's doing it. Our pharmacists, they're amazing. They're some of the smartest people I know. They've taught me a ton. And we're extremely anal about this to make sure that we're putting out really true, top quality, pure products that have in it what we say is in it. Because quite honestly, that's going to be, super important for your health. And it's also super important for the health of our company. If we're putting out junk, we're not going to last. So we're very, very careful about that. It's a really important question to ask. As far as the pills and the patches, those are commercial products that we source, but they're all high quality commercial products. And then the last thing is the DHEA, which is also a little bit interesting, which I think it always tickles me. So I'm one of the founders of the company, so we started this from scratch, and we've gotten big enough now that we're ordering DHEA in the millions of capsules at a time. And so when you're asking manufacturer for 5 million capsules of DHEA, you have a lot to say about what happens. They're doing full lots for us. And so we're in a really good position to make sure that we have exactly top quality stuff. We insist on testing to make sure that it's got in it what it has in it. And for supplements, that's important because supplements don't have the same government oversight as pharmaceutical medications. DHA is considered a dietary supplement. So we've gotten to the point where we have just a tremendous amount of control over the quality of our products, and we make sure, look, our reputation as a company and my reputation as a doctor is on the line when I'm prescribing this for you. And so we make sure that you're getting the good stuff, so to speak. That's something that is a great question to ask and important to know that that's the answer.
Thank you guys so much. Anything else to add before we keep going? All right. So the next question is from Cynthia, and her question's about weight gain. I know this is a really popular topic. She's basically never had the problem before, but as she's starting to go through her journey, and even more, she said in the last 6 months, she's just gaining weight no matter what she can do. And she's optimistic that Winona can help, but wants to hear a little bit more about that. And will it be a struggle also to keep the weight off after she starts her treatment?
Well, the meds will help with weight loss, especially if your weight gain was hormonally related. And I think, for many women in menopause at this time, it's really common to gain weight, especially around the middle. And really it's related to the stress response that our body is having. When we're constantly in this heightened stress environment, our body's in that fight or flight mode. And so our body is, even though we don't want it to, it's saving every calorie. It's saving every bit of energy it needs to in the form of excess weight. And so in my experience, once we optimize your hormone levels and we get your symptoms under good control, you'll start to notice some weight loss. And you'll start to notice that your body is going to function more optimally. Now, after that, I can't say that once your hormones are balanced, it's never going to be a struggle to keep your weight off, because I think as we get older, all people, as we get older, our metabolism changes. And as we age, it's something that we have to continue to work at. It's not something that, we can't do what we did in our 20s and expect to just drop weight easily if we make a couple small changes. It's an ongoing balance that we need to have with our eating and our activity level. But generally, balancing your hormones will definitely help, especially when it comes to that menobelly and the menopause weight gain.
Yeah. I think I agree 100% with what Dr. Kat said. And I think it's also important, though, that nutrition and what you're putting in your body is going to play a huge role, right? Because it's like HRT is not like a quick fix, weight loss drug. It's really like the lifestyle. It's really a lifestyle change where, when you pay attention to, your nutrition, right? Low inflammation foods that you're eating, as well as the resistance exercise, the hormone replacement therapy tends to, really cause that redistribution in where your weight is, right? But it's so important to make sure that you are paying very close attention to your nutrition practices, drinking lots of water, as well as like the regular exercise, because there's certain foods like wine, for example, like you may have been able to drink certain amounts of wine, like a glass every day. That may not necessarily be something that may be as beneficial for your body, as you are looking to lose the weight. Certain, things like bread may be a staple. Trying to look at what are some better options when it comes to the carbs that you're utilizing, so that there's less inflammation in your body, because there is that stress response that Dr. Kat mentioned. And so again, it's this holistic approach of allowing the hormone, replenishing the hormones and rebalancing your hormones, but also helping your body be able to shed that weight by some of the lifestyle changes that you incorporate.
I'm thinking I forget the name of the movie. There was one of these adult child body swap movies. It wasn't big. It was a mother-daughter. I think Jamie Lee Curtis was in it. But there was this hilarious line where the mother is in the daughter's body and the daughter's in the mother's body, and the daughter's shoving French fries down her face, and the mom screaming at her, "You can't do that in my body."
Oh, that's Freaky Friday. That's a remake. That was
No, it's
Yeah.
just such a great line. It's like, it's something that we all understand, but we kind of forget about it. But it's
Yeah.
like, you can't do the same things you could do when you were a teenager. It just doesn't work that way. Anyway.
I love that movie, and the daughter is named Anna, like me in the film. Fun fact there. Awesome, guys. Next question. A couple other people mentioned weight gain, so I think we summed that up. But if anybody has any additional thoughts, just drop those in the chat. Cynthia wanted to talk about managing symptoms versus addressing the root cause. How can HRT help with addressing the root cause? I think it's a very also philosophical question. It's always nice to know about the root cause as well.
I mean, the root cause of these symptoms is the aging body, and it's in our ovaries aging. We are born as women with all the eggs that we are ever going to have. And as we go through our lifespan and we release those eggs each month, with having a cycle, eventually the number decreases and decreases. And so with the eggs being lower and lower, our estrogen production is decreased as well. And so, by supplementing with hormone therapy, we're addressing the symptoms. We cannot return your body to its pre-menopause state. We can't return your ovaries to their normal state when your reproductive prime. In that sense, we can't get to the root cause and reverse this process. And that's not the goal. Like, the goal is not to make your body back to what it was in your 20s. It's, we want to give you back hormone to ease your body through this transition. Menopause is a natural transition, but it doesn't mean you have to suffer with it, but this is a normal transition of an aging woman's body. And it's, the point of therapy is to ease you through that. And so, I mean, that's my take on, like, can we get to the root cause? I don't know what you guys want to add to that.
I mean, I think we are getting to the root cause, right? Because the root cause is that our ovaries are not producing the levels of estrogen, progesterone, testosterone that they produced as in our younger years. So the fact that, we are supplementing with bioidentical hormones, right? Which, again, bioidentical can be looked at as a marketing term, but it really is like body identical, right? The identical structure and form of estrogen, progesterone, that is identical to what your body normally produces, right? We're not giving you synthetic hormones, but we're giving you hormones that are very similar in structure to what your ovary naturally produces. So I look at it as, hey, we are dealing with the root cause, because the root cause is that we're just supplementing you with the hormone that your body is no longer able to produce.
Right.
Yeah, I totally, there's a whole reason for this, but there's these people that are afraid of hormone replacement therapy, doctors. And so they have all these other medicines that treat symptoms, but they don't really treat the problem, which is the loss of production of hormones from the ovaries. And so there are SSRIs, there are certain blood pressure medications, there's this new drug that's out, all designed to treat vasomotor symptoms or the mood swings or these different symptoms, but they don't really get to what the real issue is. And the real issue is that the ovaries aren't producing hormones in the way that they used to. And so the symptoms are the obvious part, but there's a lot of stuff going on in the background. There's the increased risk of cardiovascular disease. There's the increased risk of colon cancer. There's the increased risk of dementia and Alzheimer's and all these other things that you don't even feel beyond the symptoms. And so by treating the root cause, which is replacing the hormones that your ovaries are no longer making, not only does it treat the symptoms, but it also treats these other manifestations that are working behind the scenes that you're not feeling. And that's why hormone replacement therapy isn't just good for your quality of life, but it's also good for your longevity. So this is a root cause treatment as opposed to, say, an SSRI or other thing that's designed really just to treat a symptom.
Thank you, everybody. Next question is from Nancy. It's a bit specific, but she's mentioning she's on a current dosage. She's mentioning her dosage at E2. I won't say the whole thing. She's seeing if she needs something more for brain fog. She's asking if she should get some ADHD medicine or should she talk to her OBGYN about increasing her dosage of HRT.
So I'm looking at those numbers, and that's not our medicine. That dose of progesterone is not adequate, in my opinion, to protect your endometrium. So I'm not happy with the dose I'm looking at, just from that point of view.
I concur, Dr. Green.
Yeah, I'm concerned about it. So unless you're taking another source of progesterone, I don't think you're getting enough progesterone in that cream to protect your endometrium. That's one thing we're very careful about, is to make sure that you're getting adequate protection, again, to keep you healthy. I mean, if I relieve your hot flashes, but I kill you with uterine cancer, I haven't done you any good, have I? So, that's a really important thing. And so I think we can do better, quite honestly, at Winona.
All right. Well, thank you. I think the next question we have is from Deb, and sorry if I skipped anybody. Wants to know about HRT and endometriosis and talking about hysterectomies. I know we talked a little bit about that, but I wanted to add in because she's also mentioning about endometriosis pain as well. So just wanted to see if we had anything additional to add to our previous answer.
Well, so I think that a lot of women who have a history of endometriosis that's, clinically significant endometriosis, where they've required a lot of surgeries and had significant pain, there is the fear that taking hormones is going to reactivate their old endometriosis. And there's a thing called, ovarian remnant syndrome too. And this is something I've had patients over the years, like throughout my career, have concerns with. In general, even with younger women who have complete hysterectomy and oophorectomy for endometriosis, we give them back hormones. It generally does not recause endometriosis to grow or spread. And that's something that it's something you have to talk to your individual physician about. Every woman's experience of pain is different. And sometimes the source of the pain, especially from endometriosis, could actually be from the after effects of the endometriosis rather than active endometriosis implants. And that's beyond the scope probably of this discussion. But, it's something that in general, I should just say HRT shouldn't bring back your endometriosis. That's the bottom line.
There is some data. It's not a huge amount of data or great data that this is the one place where sometimes we'll add progesterone to the estrogen, even if somebody's had a hysterectomy. Normally, if someone's had a hysterectomy, they don't need progesterone. This is one case where sometimes some people think it's helpful. I don't think there's a huge amount of data for it, but I think it makes some sense. So that would be sort of one thing that we would do different. So make sure you let your Winona doctor know about your history of endometriosis so we can consider this.
We just have I know we're right on time, everyone. We just have a few more questions left if we can hang a couple extra minutes. Next question is, do we take the medication during our cycle or stop during the cycle and pick up back after it? This is from Tammy. Thank you for your question.
I'm sorry, say that again. Cyclical HRT versus continuous HRT. Yeah. Sorry, you get it. Okay.
I can address that to what I personally do. I personally prefer to, even if you're still having your regular cycle, to take HRT every day. And the reason why I choose to do it that way is because it reduces your chances of side effects when it comes to bleeding, for example, or having breakthrough bleeding. There are some people, though, who could be candidates for cycling. Let's say if you're having a lot of really just, issues with getting bleeding under control, and you've been on, HRT for at least 3 months, and there are certain instances, but what I've found in general works best is taking it every day without taking any breaks. I don't know if anybody else wants to add their experience here.
So yeah, there's a couple of studies that came out 15, 20 years ago that said that taking estrogen and progesterone together had a slight increased risk of breast cancer. We already talked about this, but taking estrogen alone did not. And so people then thought, well, gee, what if we try to minimize the progesterone exposure? Will that help? And so about 15 years ago to 10 years ago, in that time, it became sort of popular to do this cyclical HRT, where someone would give estrogen every day and then only give progesterone. And there were different ways of doing this. Some people would do it every other day. Some people would do it 14 days out of the month. Some people would do it 14 days every 3 months. And all these different schemes came out. And enough time has gone by where that's been looked at. And really what's come out of that, there was just a paper published maybe 6 months ago. And they said there was absolutely no benefit to it. So it didn't help. And it caused more side effects. And so the sort of the punchline was, well, it's a good idea. Nice try, didn't work. Doing HRT every day for most people is the best way to do it. But yeah, there's always edge cases where there are certain patients where we'll do cyclical HRT for other reasons. But for the most part, continuous HRT, taking estrogen and progesterone every day is what the latest data shows is really the best way to do it.
Thank you, guys. We're going to close. There's 2 more questions, so we're just going to close with these. So thank you, everybody, so much for your participation. The next question is about, there's a couple of things going on, but wanting to know if they're still having their period, they are their ADHD symptoms are worsening while they're going through perimenopause, and then they want to know how they can convince a clinician that they would want to supplement the estrogen level and not just the progesterone to improve their mood and overall symptoms. So 2 parts there: ADHD symptoms during perimenopause, and talking to a clinician about what their needs are in terms of levels of estrogen and progesterone.
When we talked about earlier how ADHD symptoms can get worse with, in that constellation of brain fog, I don't know if we want to kind of revisit that all again. We talked about how that kind of goes hand in hand. The big question and what I hear here is, how do you convince your doctor to start ordering things for you? You're not going to convince a physician to prescribe a treatment that they're not comfortable with. However, I will say that I have had a lot of patients that come to us at Winona because they don't have a doctor who's willing to prescribe. And then they go on our treatment, they feel wonderful, their symptoms improve, they do great. Then they go back for their yearly checkup and their doctor's like, wait a minute, what are you taking? And they start to see that their patient's doing great, health-wise, things are going well. And then I've had a few patients where they come back and they say, guess what? My doctor saw how great I'm doing on the Winona meds, and now they're willing to consider prescribing for me. So I think little by little, we're kind of changing the climate and helping to show providers out there that, yes, this is this is a valid treatment. Women deserve treatment to improve their quality of life. And I think one by one, we're starting to change the hearts and minds of some of the doctors out there that were unwilling to prescribe before. But as the patient going to a visit, you're not going to be able to show them stuff to convince them to prescribe. I think it's more like showing them the proof in the pudding, that you're getting treatment and doing well with it. That would tell them a lot more than trying to convince them with a verbal argument.
Yeah, thank you so much for that answer. This is our last question for today. Thank you, everybody, so much for joining us. This question is about autoimmune flare-ups, or I guess just issues with your autoimmune system and going on through menopause, and then also being a patient at Winona. They're on their treatment so far for 6 weeks now. Also mentioned joint and bone issues as well.
There's some indirect evidence that HRT should decrease autoimmune flare-ups. We see that in pregnancy when the hormone levels are high. People tend to sort of honeymoon in a lot of their autoimmune diseases, not always and not all of them. But there is at least some indirect reason to think that HRT may help with that. But certainly it's not a primary treatment for autoimmune disease. HRT can also help with joint pain, but it sort of depends on what's causing the joint pain. So if you were a volleyball player in college and you destroyed your knee and your joints have been hurting ever since, HRT is probably not going to do much to help that. Maybe a little bit because it works as an anti-inflammatory. On the other hand, a lot of women do experience joint pain as one of the symptoms of the menopause transition. And in that case, HRT can be very helpful for that. So it sort of depends on why the joint pain is there. HRT is also, we haven't really talked about this, but very good for your bones. So estrogen is very important for bone health, along with calcium. But it does decrease your risk of osteoporosis and osteopenia. So you don't break that hip in 20 years. So it's actually, that's another one of those sort of silent benefits that you don't realize is going on that's happening behind the scenes. So it does also help with bone health. I don't know if either of you have anything to add.
No, I would agree with what you said about the joint pain. And I often have patients that, hope that the hormone therapy is going to be this magic bullet for every ache and pain they've ever had. But you're right. Like it tends to be, a combination of our life experiences that cause a lot of our other medical issues. And it's something that, may not be fixed by HRT if it was something that was pre-existent. So I agree with you on that one.
I just gave one of our founders is a 30-year-old guy. I was on a call with him and I don't know, we got chatting and somehow it got to like what he should be doing. And I'm like, watch your joints, don't beat up your joints now because when you get to be my age, you're going to regret it. So, some of that you can't really get back. But
right.
Again, joint pain definitely can be a symptom of the menopause transition. And for that type of joint pain, HRT can help quite a bit.
Yeah. And I think it's so important to keep moving. If you don't use it, you lose it. And that goes with, the whole libido and sex thing, but it also goes with our joints and arthritis as we age. You got to keep moving to keep your body healthy.
Well, thank you, everybody. I certainly learned some things, and I hope everyone else enjoyed it. If nobody has anything else to add, any last-minute thoughts from the doctors, we're going to go ahead and close this event.
Thanks for coming, you guys. Yeah.
Yeah, thanks everyone for dialing in. Yeah.
I hope this was useful for you to spend an hour with us.
Yeah, thank you guys. And if anybody has any other questions, you know how to reach us on the website. There's lots of different ways you can reach us. So just jump in that chat there if you need something additional or have any questions. And thank you everybody for your time today.
Have a good night, everyone.
Good night.
Bye.
Bye.
Bye.